Good morning, everyone. I was just talking to the early arrivers that I hope that they had a good dose of coffee before you came on a Friday morning to hear about an hour and 50 minutes worth of biostatistics refresher. So I'll try to keep it lively, but feel free at any point if you have a question or a comment or want to make it more of an interactive discussion, please feel free to do so. We do have some people who are joining us online. I hope that they'll participate in the same way. By the way, online people should have access to microphones. If you have one on your computer, feel free to speak up at any point. So this is a lecture series that the Department of Biostatistics and the University of Kansas Cancer Center and the Frontiers CTSA co-sponsors every summer. If you've been here before, welcome back. You'll probably see a lot of the same material. It happens, the discussion changes every year though, so I hope that you still continue to get something out of attendance here. We will be recording and posting this for later viewing, so if there's something that you might want to see again or rehash the discussion on your own, it'll be up as a link on our department webpage, and I'll show you where that's located. It'll be up all year until we do it again next year. And then at the end, I always like to get some feedback to see if maybe there's a topic that we didn't cover that you'd like to see covered, or maybe something to spend more time on that maybe we brushed over too quickly. But I want to, here's the link to the department's webpage. You can navigate there from the main page of the MedCenter website, or you can go there directly by typing biostatistics.kumc.edu. And then looking on the left-hand side under events and lectures, you'll be able to find everything that we've done as a department that we may have recordings posted. My name is Jo Wick. I am a faculty member in the Department of Biostatistics. I've been here since 2008, and I have kind of transitioned into a role in our department where I do a lot of educational activities. So that's why part of this is because I've been doing this as Dr. Mayo, I think, started it and transitioned it over to me in 2011. So I also oversee our graduate programs and a little bit of teaching in the medical school curriculum. So if you ever have a question about needing statistical support for maybe your thesis or your research, feel free to contact me directly, and I can either steer you towards our tutoring lab, because we do have PhD students in our department who sit in a tutoring lab every week and welcome any student into the lab for statistical support on homework or research. But if it's not appropriate to push you in that direction, I may steer you toward faculty support, which we do provide on this campus as well. Before I get into a little bit of resources that are available to you all, both as students and as researchers, I wanted to go over briefly the objectives of the class. This class is not designed to send you off and allow you to run your own statistics. Some of you can do that. You do have enough training to do that in certain scenarios where it's obvious that maybe a t-test or a Fisher's exact test or a linear regression is appropriate. The idea here is to help you to refresh your memory about how what the role of statistics is in the scientific process, and specifically in evidence-based medicine, to help you understand the features, strengths, and limitations of all the different types of studies that we do, from descriptive all the way up to randomized controlled trials. Again, to understand the limitations of the different designs, so whenever you see someone make a statement in the literature about X causes Y or X is associated with Y, or when you're writing your own manuscripts based on your research, that you understand the proper interpretation of a finding as it relates back to how the data was actually generated from one of those experiments. And then going over the usual things that you would see in a stats class, with an emphasis on proper interpretation and understanding how to identify maybe the limitations of an analysis based on different aspects of its design. So again, that's the purpose. It's really to make you remember some things maybe that you heard a long time ago in graduate school or even in undergrad, things that we don't necessarily work with every day. I'll give you those in the context of analysis techniques that are very common in the literature, so hopefully this will improve your ability to critique the literature in your own field and maybe improve the way that you approach your own studies as well. Dinesh is our department's director of research, IT, and he wanted to join us today, but he's actually dropping off his parents at the airport. They're going back home. So rather than being here in person like he is every year, he recorded a video, and I've linked to that in the slides, which, by the way, I got several requests overnight for copies of the slides, so if you haven't checked your email this morning, you should have a copy. Probably too late for you to print out and write on, but they are there, and I'll send out the slides for the next 3 lectures next week. But Dinesh has recorded a brief video to discuss some of the infrastructure that KUMC has set up and supported for researchers. If you have any questions about this content, we can discuss it. I might not have the answer, but I'll give you Dinesh's email at the end.
Hi everybody, welcome to Introduction to Biostatistics for Clinical and Translation Research class. And my name is Dinesh Mudranthakam. I'm the Director of Research IT placed within Department of Biostatistics. Usually this is one platform where I take the opportunity to come talk about all the different resources that are available for the researchers here on the campus. Having said that, I'll get started with just a casual data architecture or a view that I would say. Most of the times we try to keep it simple by saying one-stop shop, because we care for the data from the beginning till the end, because if the data at some point is ruptured or is not collected properly or is not organized properly, that could result in various outcomes. So that's why this picture here depicts like how once a researcher gets a new idea or new protocol they're thinking about, they might have to get in touch with one of our statisticians, and our statisticians will help them or even just review them and provide them some comments about their idea for this protocol. When I say idea, it's about the aims that they are thinking about. And if there is some change with the idea, for suppose like calculating the sample size or power analysis has to be changed a little bit, they'll be happy to help and provide feedback. That way what happens is then they will be involved upfront with you guys, and you can see what would be the sample size, what would be the variables that would be required, and if there is any randomization required, then how, what kind of randomization, whether it's clustered or Bayesian adaptive or any other randomization that's required. And they might also help you out how to keep up with your accrual tracking if that's required for your protocol. So this is the model that we have been developed here, is to help the researchers, guide them with their protocols and ideas from the beginning, and make sure that not just the idea is successful, but the entire study and the study team members achieve success by recruiting all the patients that are required for doing the research. So I'll talk a little bit about the clinical trial management system that's available on the campus. It's also called as CRIS, Comprehensive Research Information System. This is basically any clinical trial that has funding or managed by research institute. All that clinical trial information would be entered into this system. One step ahead, Cancer Center also uses this system to track their patient information, and they generate all the annual reports and monthly reports, which are sent directly to the NCI. Some of the standard or basic features of the system is there are standard forms and standard data dictionaries that we have developed. There are ad hoc queries, which end users, they themselves can create a query and run it themselves. There is also custom reports that we can design and the end users can use them. There are study calendars to keep track of the longitudinal data. There is financial module used to keep track of all the finance related stuff to the study or the clinical trial. And on top of this, the last but not the least is the randomization feature, which automatically the system will help the study coordinators to randomize the patient and assign the patient to the next available treatment from the standard randomization table generated by the statistician. So this is one quick look at how the randomization happens here. You can see this particular patient has been randomized and been assigned to this treatment. This is a blinded study here. That's why the treatment is given a black stripe as a name. The underlying treatment here is a little different. It could be 100 mg or 200 mg of certain drug. This is to help keep the coordinators blinded. But on the other side, the flip side, we the informaticians exactly know what black stripe means, what's the dosage on that. And this is basic demographics that you're seeing. This is all a test environment, the test patient. You're able to see when they were screened and how they were randomized and what's their randomization number here. Quickly, I just wanted to show there could be automated reports like this where if a study team wants to keep track of the patient's visits window, like what the patients are going to be coming in for the next week. So there could be a report that could be generated based upon their calendar visits, saying that these are the set of patients who would be coming in the next week or so. This helps the coordinators or the study coordinators and the researchers to keep track of their own patients and follow up with their patients on time to collect all the data. So there is one other update that we made since my last presentation here in this class is the accrual app that we developed with the support of our cancer center. So I would take this opportunity to show you guys the accrual app. This is the accrual app. You can simply go to accrual.kumc.edu to access this application. This application, you can see all the data is being pulled from our clinical trial management system, which I was talking a little earlier. The basic information till this column that says estimated date, till the enrolled column is all the information that is flowing directly from our CTMS system. The last three columns is the algorithm that Dr. Gajewski and their students have developed to estimate when this particular study would practically come to an end based upon the accrual rate it currently has. So I'm just going to pick on one study here, this breast study that we are seeing for Dr. Priyanka Sharma. The sample size here is 100 and the duration is 24 months, and technically the study has kick-started on July 9, 2015, and so far the study has enrolled 79, and so 24 months is probably from July 2015, it will be 2017 of July. This has to come to an end, but you can see it's going to take a little more than what was expected, probably another 6 months. because of the rate it's currently accruing. And you can look at these plots which would show you this is the target, the red line is the target, and this little white line is the current enrollment. So there's a little bit of lag, not too bad, but the huge sample size here, it's going to take a little more time to achieve this targeted sample size. So similarly, you can see some of the other studies here that are currently ongoing, and all the studies that are listed here are pretty much related to Cancer Center. So all the studies that are being managed by Cancer Center. So this search, little search here is pretty handy that could be used to do different searches. If, say, for suppose I would like to just look at all the head and neck, I can just type head, and then it will list me all the ongoing clinical trials that are open as of now. I could use these columns to sort, or if I just want to look at bigger list, I could, and the header is fixed, so it's easier for the users to scroll and look at all this information. So this is pretty much the accrual app. I'm going to go back to my slides here. This is the same thing that I showed. And the other thing is the specimen system. Our team also helps our biospecimen shared resource manage their inventory using the specimen system, which is also called Open Specimen, which is powered by Krishnaga. So in case if you guys need any help with the specimen, feel free to contact us. Last but not the least, this is a website. There is few other things that is available, like softwares. IPA is Ingenuity Pathway Analysis, which could be used to look into some of the sequencing data and other data. So please feel free to go visit this website and look at all the other information that is available here. If you have any questions, or if you want to talk to any of our faculty members to discuss your upcoming new ideas, then please feel free to contact our project manager, Megan Tremblay, and she'll be able to coordinate a meeting with you and one of our faculty members, whoever is available, or she will match and pair the right expertise from our end. In case if you all have any questions related to the resources that I've just discussed here, or any other informatics kind of bioinformatics kind of questions, please feel free to contact me at this is my email address, my phone number. Thank you.
Okay, that was Dinesh. He usually joins us live, but again, he had a conflict this year. So if you have any questions about the tools that are available to you as researchers, please feel free to contact him directly, and he can steer you in the right direction. So without further ado, let's get into the actual class content. Today will be really more around speaking the language of statistics, so some core concepts. I hope that you're not disappointed that we're not going to dive right into regression or anything today. That will actually start on next week, and we'll spend the remaining 3 sessions really focusing on methods, interpretation, proper selection of methods, proper application of methods, when we begin with quality of evidence on July 14th. We will also on July 14th discuss a little bit about the design of experiments. So we'll go through the different types of experimental designs that are generally applied in medical research, and how each of them has a specific strength or limitation, and I'll try to discuss maybe why that limitation is there based on how the experiments are actually run. And then we'll get into hypothesis testing shortly after that and work through a lot of the more common clinical types of questions that you may have. At any point, feel free to speak up, ask me a question, start a discussion, I would like this to be a little bit more interactive than not. So in step one, we're going to learn to speak the language of statistics. I always like to, since I'm a statistician, advocate for the use of statistics not only in clinical and translational research, but from the beginning of the research paradigm, from the scientific method, from its very beginning on. Because we really function, we are a science ourselves. We're really domain neutral, so we can be applied in any area where you're working with data and you need to make a decision. So we are, in essence, the science of decision making, and the key is in the presence of uncertainty. So if you knew the truth, you wouldn't need a statistician. What we bring to the table is the ability to help you quantify how, quote unquote, good your conclusion is. So there's always a little bit of uncertainty associated with any results from any experiment. And so hopefully we help you in the earlier phase of your research design a study to minimize the uncertainty that you have. That way when you get to the end, you get valid and reliable conclusions with, again, minimal uncertainty. That's not always possible given the logistics of research, but that is the goal. Some examples where statistics is used: you may want to predict a patient's long-term chances of successfully quitting smoking when therapy includes both nicotine replacement and varenicline. You may want to estimate the prevalence of obesity in the United States, or the survival of patients after transcatheter valve-in-valve implantation inside failed surgical valves. So these are some examples that I pulled from the literature. This is from JAMA 2014. This is actually the abstinence, continuous abstinence and point prevalence abstinence rates. This is a very common type of table that you would see in a journal article, and most often what I try to do is help with the interpretation of things like an odds ratio, which is not really all that intuitive. And more emphasis has been placed on interpretation, proper interpretation of a p-value. So I hope we have a fruitful discussion about that today. When are p-values meaningful and when are they not meaningful? We'll probably get to that next week as opposed to this week, because I want to lay the foundation first. And then things like point prevalence, rates, those kinds of things. So I'm hoping to address a lot of these things. Confidence intervals. What's the proper interpretation of a confidence interval? Something like this, where you see kind of cumulative incidence rates. How would you read a graph like this? What's the proper interpretation, and maybe how do I see that there is a benefit to maybe one of these types of valves relative to another? So that is what statistics does. We allow scientists, we facilitate scientists who want to help model the uncertainty inherent in their investigations. So there is some underlying truth. Oftentimes in the context of something like hypothesis testing, we make an assumption about what the population looks like, and then we observe pieces of that population, preferably through some kind of a random sampling technique. So we get what's called a representative sample. And the sample is something that we can directly observe. And so the idea then is we use tools of probability and statistics to discuss what are the chances that I would observe a set of patients from this population with these particular features that I actually see in my sample if the population is actually how I hypothesize it to be. And that's the underlying, the general process behind scientific investigation. Now, I use the word population. I might not be looking at a population. I might be looking at a phenomenon. So in basic science, you might be interested in the relationship between these things that you can't observe directly. And so we draw or generate data from those phenomenon in order to figure out if our hypothesis about the relationship between all of these different things is actually feasible given the data that was generated by the experiment. One of the ways that statistics helps, and statisticians in particular, is to help you think about what are the other possible sources of variation that could cause the outcome that you actually observed. So as a statistician, we're trained to think about variation and sources of variation and try to throw them into different bins, if you will. Now, that's why I think it's very useful if, as a researcher, you work with the same statistician over and over and over again, because I find that we're not trained in your science, but the more we work with you in the same field, we get to understand the outcomes that you're working with and the types of experiments that you do, and we start to think more about potential sources of variation because we understand more about your science. This is a specific example in infertility. So suppose you are interested in learning more about why couples have problems conceiving a child. You have a hypothesis based on previous literature or your own observation that there's some particular toxin that they're getting exposed to that results in them having difficulty getting pregnant. And so you decide to conduct a study where you would have a control group, in this case a set of women, a group of women who are not exposed to this particular toxin. And then you take a group of similar women who are similar in age and other features who have also been exposed to the toxin. And your idea would then be to record the time it takes each of them to conceive to try to draw inferences about the relationship between this toxin and the difficulty they're having getting pregnant. So again, this gets back to variation in the time to conceive and how for an individual woman there are many sources of variation for their specific time. So there's obviously natural variability in time to pregnancy. We tend to lump this, what we'll call noise, into just a category called error because it's many causes aside from a toxin that we can control for instance, age or some other factors. But there are things that are unknown causes or sources of variation. So we try to make our groups as similar as possible to minimize this natural variability. But suppose that you determine, after you've conducted your study, that the females with the greatest exposure to the toxin also had the most difficulty getting pregnant. So you actually see an effect between the two groups, the exposed and the unexposed, over and above what could be considered just natural variation in time to conceive. The problem, as always in any endeavor, is that there may be things, sources of variability or noise that you didn't consider, meaning you didn't really measure it because you didn't know it existed. And that's always a limitation of any study because you can't consider every possibility. All we can do is try to conduct the most rigorous experiment possible to minimize the chances of an error in our conclusion. So let's think about the types of errors that could happen in this particular study. What if it turns out that women who smoke while they're pregnant reduce the chance that their own daughters will be able to conceive because the toxins from the smoke involved in smoking actually affect the eggs of the female fetus. So the idea here is you have to go back a generation and look at the grandmothers of these women and measure their smoking behavior leading up to pregnancy and during pregnancy in order to figure out if this has an impact on the daughter's ability to conceive. If you didn't record this or didn't know to record this, then you actually could draw the wrong conclusion about this toxin that you're interested in investigating if smoking behaviors of grandmothers, if you will, have a real impact. So that's where we think about different sources of variation. We have the toxin of interest. We have what we call natural variability or noise that can be attributed to other things that are not of interest to us but we have to control for. And then this, what's called a lurking variable, which is the smoking behaviors of the mothers of these women. So let's think about what kind of error we would make here. We have the two groups. One is unexposed to the toxin of interest. One is exposed to the toxin. This obviously is a contrived example, but let's suppose that those who were unexposed to your toxin of interest were also unexposed to smoke from their own mothers while they were in the womb. Likewise, those who were exposed to your toxin, the majority also were exposed to smoking while in the womb. This situation results in, again, what's called a lurking or a confounding variable. I like the word lurking when we don't really know that we don't understand that it's a potential source of the effect that we see. Lurking seems to mean it's hiding. Confounding is a more general term for any variable, measured or unmeasured, that could result in systematic biases in our conclusions. So the real question is here, which of these sources of variation is the root cause of the difference in the time to conception that we actually observed? Is it the toxin of interest? Is it this other toxin, which we're not interested in, we actually didn't measure? Is it a combination of the two? And the problem is, when we see this difference, if the truth is that it's this lurking variable, we've made what's called a type 1 error. We've rejected the null hypothesis, and the null hypothesis is that these two groups have similar time to conception. We reject the null hypothesis when in fact this toxin has no effect on time to conception. And so this is always a possibility. What we try to do is design studies in such a way that we minimize the chances of this happening. Yes? Correct. Well, it's correlated, does not affect, associated with. So here it is associated, right? It's associated with the exposure. Because notice I said if you're exposed to the toxin of interest, you're also exposed. The chances of you being exposed to this lurking variable, this lurking toxin, are high. And if you're unexposed to one, then you're likely to be unexposed to the other. That is a total fluke, right? Because there's no reason to think that one would cause the other. Like because your mother smoked, you're also going to. So it's an association. You don't have to have causation or a causal relationship. All you have to have is, even by random chance, some kind of association between those two. And I've just stated that this is a touch screen, that the exposure that's lurking is associated with, we don't know cause and effect, but let's assume it's causal, is causing the effect that we actually see. So you do have that situation here. And this type of relationship where you have an association between this lurking variable and the factor of interest, that actually results in something called bias. It's a specific type of variability that you see in experiments that you really need to minimize, whether it be through your inclusion-exclusion criteria, whether it be because you're recording, the way that you randomize, you might stratify on certain factors in order to minimize that. So as a spoiler, next week we will talk about all the ways the different types of studies try to minimize bias, which is again a specific type of variability. It's systematic variability in one direction. Another problem could happen though with a lurking variable. A lurking variable, like this smoking exposure, rather than being associated with the exposure of interest, it could just cause additional variability in the time to conceive. So here's an example, again contrived, where we have our two groups, unexposed and exposed to toxin. And we didn't record whether or not these women were exposed to smoking in the womb. But because this has an influence on the time to conceive, it's creating additional noise that we don't have the ability to control for. So in this kind of situation where we have increased noise, the noise to signal ratio is actually much smaller than it would be if we had cleaner data. At the end of the study, notice that we recorded time to receive, and we actually conclude here that there is no difference. There's not a big enough difference to detect using the methods that we have in place. So we end up with a statistically insignificant result, but the question is that because we have a bunch of noise in our data, we have noisy samples? Or is it because there's really no relationship between this toxin and time to conceive? So if we concluded no difference, when in fact there actually was a relationship between toxin and time to conceive, we would make what's called a type 2 error, failing to reject the null hypothesis. And so both of those are a possibility when you incorporate or when you try to investigate a relationship between an exposure and an outcome or a treatment and an outcome without putting in place proper techniques from experimental design. And we'll talk about those again next week. One of the things that we could do very quickly in a situation like this wouldn't be feasible when you're looking at exposure and an outcome. But if these were treatment groups, what could we do rather than observing treatment that was assigned based on clinical decision making? We could do this in the form of a randomized trial. We could blind. We could have multiple control groups in order to try to tease out the variation in the outcome and attribute certain fraction of that variation to different sources, whether it be noise, whether it be a particular confounding factor, whether it be any of the different types of biases that can result from being observed. So observer bias could come whenever you could minimize that by blinding. Those kinds of things are things that we need to think about whenever we look at the results of a study and when we're designing our own. So in the previous example, we had a type of variation in our outcome called bias. Here we have a type of variation in our outcome that's not good either, and it's just called noise. Just increases the variability in an outcome, which is also not a good thing because it can result in missing a meaningful effect. So again, conclusions always come with some amount of uncertainty, and statistics uses the tools of probability to quantify that uncertainty. So that's where you get things like p-values, levels of confidence, standard errors. Another key factor of statistics is that it allows us to put forth proper interpretation of evidence in light of the context, the design that produced the data that you were working with. So for instance, the easiest example is that association versus causation, and why you would never interpret an association as a causation unless you had proper controls in place. Any questions about that introductory example? The purpose of that was just kind of to lay the groundwork of where we're going with the class. Let's begin briefly with a discussion about evidence-based medicine. This actually could be evidence-based anything, evidence-based practice in whatever your field is. It involves gathering evidence in the form of scientific data and then applying the scientific method to inform practice, whether that be clinical practice, establishment of new therapies, development of new therapies, devices, policies, anything like that. So it's a very simple definition that I think oversimplifies the process of evidence-based medicine. And a big gap that's not listed here is the subjective decision-making that always goes into evidence-based medicine. You ultimately make the decision about how you're going to treat a patient, and that decision is based on all of your knowledge to that point, and then sometimes there's a gap in that knowledge, and so you have to do what you feel is best for the patient. There are different levels of scientific evidence. I think we're all aware of that. Formally, there's several definitions here, type 1 to type 3. And again, depending on the type of experiment or the type of observation that generated that evidence, it determines the strength of the evidence. So type 1 evidence, which is the least convincing, if you will, it has the more limitations or stars next to it is that's based on descriptive studies and epidemiological type of studies, so maybe observation-based. Type 2 is intervention-based, so we can think of that as like a randomized, even a randomized controlled trial in this case would generate intervention-based. And the reason the randomized controlled trial is not the strongest evidence, if you will, is because it's taken out of context. How many times have we seen something work really well in a controlled setting, investigational setting, that when given to flawed humans who don't take their pills like they're supposed to, or take other things that they're not supposed to with their pills, it ends up not being as good. So we'll talk a little bit about the difference between what a randomized controlled trial is doing, what it's estimating, which is the efficacy of an intervention, versus what actually happens when this is given to the broader population, and that's the effectiveness of it. And those two things can be very different. Evidence-based practices result, ideally, in things that have a higher likelihood of successful patient outcomes and more efficient use of healthcare resources. The reason behind that is because practices that are evidence-based have to some degree been investigated rigorously and found to be superior in some way to other known alternatives. And this process underlying this whole thing is, again, the scientific method. I'm assuming I don't need to go into this. It's just the way we observe and then continue to move our own scientific field forward. We might start, for instance, with a case study. We might observe someone who was treated with a therapy in a particular way who responded really well. And that will pique our interest, and maybe we hypothesize about why that person responded the way that we did. So then we go out and do a case series, whether it's published or not, it doesn't matter, it's the same thing, a case series where we go and observe, we try to find other patients who are treated in the same way, who are similar to this person, and see if they're responding in the same way. This is all observational data. There's no control over the potential sources of bias that could result in these people being responding the way that they do. But that may be enough preliminary evidence for us to think it's worth maybe applying for funding to do a small pilot study. So notice what we're doing is we're continually observing and revising or refining a hypothesis. And our experiment may just be observing a single patient, it may be observing multiple patients, it may be a full-fledged pilot, which then may lead us to like a phase 3 randomized controlled trial. When I say phase 3, I'm talking more in the drug discovery realm, but a randomized controlled trial to really get stronger evidence that our hypothesis about X causing Y or X being associated with Y is actually a valid hypothesis. The key here is, though, that this never stops, because once something is determined through maybe multiple randomized controlled trials or even meta-analyses that are published in the literature to be the best option for patients, there's still uncertainty with that. And we can always see, and we do see, evidence generated in later studies, larger studies, studies that are performed in maybe a slightly different way, that could contradict our hypothesis to that point. So we have to always acknowledge that uncertainty and fall back on the fundamentals of the scientific method to try to come to the best decision for where the current state of knowledge is. In clinical evaluation, I've already kind of referenced this. Observation comes in the form of evidence or data. We use that data to revise or refine not only the hypothesis, but how we design the study. And then we actually run the experiment, which then generates data, which then either totally revises our view of the phenomenon or confirms what we think, and then we continue to go and we move forward in the scientific process. I alluded to the fact that we would never jump in with a randomized controlled trial until we had evidence that it was necessary. So the type of the study that you undertake really depends on the purpose of your research. And very early on in the process, we generally are only wanting to explore relationships. I get a lot of people who come to my office and want a power calculation for a study when really their end goal should only be to explore or describe what's going on. And power is tied, which we'll see next week, directly to a testable hypothesis. So if we shouldn't be testing hypotheses, if we should just be estimating and exploring things, gathering preliminary evidence or preliminary data to support the design of an adequately powered study, we're probably needing to do one of these. We need to undertake a strategy that's lower on the list. Yes, there may be ambiguity in the results, but we want to make sure that we have evidence in favor of all the resources, in favor of us actually expending all the effort and time and resources for that randomized controlled trial. So the purpose, again, determines really, what you should be doing design-wise, and the different strategies can be classified into one of these 5. Naturalistic observation is kind of like epidemiology, where we just sit back and watch. You might be doing this in your clinical practice or in your lab, just seeing what happens. A case study is a really thorough and rigorous investigation of a single patient or a single trial. I'm not sure what it would be in basic science, but generally a single patient where something unique or interesting happened. And that usually produces a hypothesis for you. Surveys, quasi-experiments. A quasi-experiment would be like a case control study where you don't employ randomization, a cohort study, things like that. A true experiment is something that has all of the bells and whistles, all the complexity of a randomized controlled trial where you try to produce data in a way that you have high confidence that it's not only valid, but it's reliable, and it will give you the best and clearest picture of the effect that you're investigating. So as we increase our control over the experimental setting by employing, for instance, randomization, blinding, actually including control groups, we decrease the ambiguity of the results. So we minimize the chance that it's a lurking variable, for instance, or a confounding variable that's producing the effect that we see, minimizing the noise in the data, minimizing all the different sources of bias that could arise by knowing what treatment you got or knowing what treatment the patient got if you're the one evaluating their response. This is a very general flow chart, if you will, hierarchy of the different types of studies, where you see in general we lump them at the highest level into descriptive and analytic. Descriptive studies are things like case reports, case series, cross-sectional studies. So single point in time, we observe both the exposure and the outcome or the treatment that was given to the patient simply as a function of clinical decision making, not because there was any, it wasn't necessarily an experiment. So this cross-sectional may come from retrospective chart reviews, for instance, versus analytic studies that can then be classified into quasi-experiments or observational studies and experiments, which is, of course, the randomized controlled trial. The thing that differentiates between an observational study and an experiment is randomization. In an observational study, like a case control study, the exposure happened, whether that exposure is to a toxin like smoking or to a treatment, different types of treatments. So case control or cohort study, those are strictly observational. And an experimental study is one in which randomization is put into place. And again, they increase in complexity, they generally increase in cost, they increase in time, resources in general, but the evidence that's generated is much stronger, and you actually have a higher degree of confidence in the conclusions if the study is done in a scientifically rigorous fashion. Here's an example of an observational study on serum cholesterol, serum total cholesterol, and maybe, how can we explain why different individuals have different serum total cholesterol? The idea behind this study may be that you're trying to develop some treatment or some set of guidelines for getting people's cholesterol down if they're in a range that's problematic. So we think that there are different things that could cause two people to have different serum total cholesterol. Things like their age, maybe their gender, education. I don't know, it could be a surrogate for some other thing that's actually there. Use of blood pressure medications. And then the biggest question is, how does smoking affect the associations between these two? So you're really here just trying to explore. So you're not doing a randomized controlled trial. You recruit 3,000 subjects over the course of 2 years. You take their blood samples, and they also answer a cardiovascular disease risk factor survey. So your outcome here is the serum total cholesterol. The factors of interest, let's just stick with one, blood pressure meds. These are observed, so the patients are telling you, the subjects are telling you what they're on, and they were given that advice, that prescription by their physician. They were not randomly assigned. What are the potential confounders if I'm looking at the relationship between use of blood pressure med and serum total cholesterol? What other things could confound a relationship that I could describe from this kind of a study? Diet, genetics, other meds, BMI, yeah, their actual weight, whether they're obese or not. Compliance with blood pressure meds, that's a great one. I actually didn't even think about that one. Yeah, any lifestyle or environmental factor or genetic factor, and maybe even things that you just can't explain. So there are a lot of confounders here. If we go back to this idea of association with blood pressure med use, so a confounder that could result in what looks like increased serum total cholesterol for people who use these blood pressure meds. What is a lurking or a confounding variable that could be associated with use of blood pressure meds and also associated with high serum total cholesterol? That would be the usual scenario we wouldn't want, because that would result in a biased relationship between the two. So think about people who take blood pressure meds. Is there some kind of other characteristic that they may have that could also result in them having serum total cholesterol? Obesity? Yeah. Other diseases? Yeah, other diseases. So these are the kinds of things that limit observational studies. We could record all of those potential confounders until we're blue in the face. But guess what? If at the end of the day, all of our people on blood pressure meds also have this other risk factor for high cholesterol, then this study is a failure, because we cannot tease out whether or not the blood pressure meds are the cause or the root cause of the elevated cholesterol, or if it's this other disease or this other medication that they're also taking, or the fact that they're more obese than those who are not currently on blood pressure meds. This is an example of an experiment where we don't necessarily have those issues. Will a new treatment help overweight people with diabetes lose weight? So we have 40 obese adults with type 2 diabetes. In the design, so not only can we use things like randomization and blinding and controls, we can also think about who we include on the study, so we can hopefully minimize the noise in the data. So we decide that because maybe gender, sex is a potential factor in this relationship, we limit our study to equal numbers of males and females, with the idea that we would randomize, maybe 20 females, we would randomize them equally to treatment versus placebo. And then within the males, we would equally randomize them treatment versus placebo. So that's a type of randomization that has restrictions on it that if we know in advance and that it's a feasible approach, if we know in advance that sex plays a big role in this relationship, we want to find ways within the design of the study to manage that source of bias. And they've done it here by restricting randomization to within females to make sure females are in both groups equally and males. So we don't get all females or predominantly females in one group. The reason why something like this is important in a study of size 40 is because what we will see is randomization really only works in theory in large studies. If I stood up here and did a randomization routine for a sample size of 20 where I put 10 in one group and 10 in the other, I could truly randomize, but then we could very easily see some chance differences between the groups and potential confounders because our study is not big enough for the benefits of randomization to really kick in. Which is why, again, even in small studies where randomization is used, you should be very diligent about checking for imbalances in your groups on things that could affect your outcome. So here the outcome is weight loss, and the factor is treatment versus placebo, and this is the gold standard. We randomized, we used a double blind. Double blind means that not only did the subjects, the obese adults with type 2 diabetes, not know what they got, but the person who was evaluating their outcome also didn't know what they got. So it removes two sources of bias that can play a big role in incorrect conclusions. So the different ways statistics facilitates evidence-based medicine, it really, again, goes through the spectrum. We can divide statistics, the tools of statistics, into really three categories. Experimental design is really where it should start. So if you have an idea, a project idea, and maybe you only have your aims listed, it's a good idea to consult with a statistician right away, unless it's going to be a relatively small, simple project. But even in that case, you might want to consult with a statistician who can help you think about the different techniques that are feasible for not only the planning process of your experiment, but for conducting it as well. Again, to minimize sources of variation, either noise or bias, so you get valid and reliable conclusions that are as strong as they can be within the limitations of your research. So people often tend to think of statistics only occurring at the back end when it really should be occurring from day one, because all of that can affect the quality of your data. Then once we get past experimental design, which is what we talk about next week, we'll get into descriptive and inferential statistics. You might also hear this called exploratory data analysis and confirmatory data analysis. So there's lots of different phrases used for these two approaches. When we explore data, we're describing it. We're looking for patterns. We're processing it, making sure it's clean. We're doing summaries. We're presenting graphs and tables and things like that for visualizing our data, which is always an important first step before we actually get into testing. Once we've, and by the way, not all studies actually use inferential statistics. One part of both descriptive and inferential statistics is estimation. So you may describe the results of your study using confidence intervals, point estimates and confidence intervals, and then not go any further because that's beyond the scope of your study. But inferences can be made using confidence intervals, because if you're estimating the effect of a treatment relative to some placebo or some control, and the 95% confidence interval is completely above 0, where maybe you're looking at a difference in the average responses, if it's completely above 0, then you can conclude that there is a non-zero effect, non-zero treatment effect, because that confidence interval is directly tied to maybe the t-test and its p-value that you would get if you did the actual test. So these three bins, if you will, really encompass most of the techniques that we use in statistics that facilitate evidence-based medicine. Graphical and numerical summaries, and then we do estimation and hypothesis testing when it comes to inferences, but estimation can be part of description as well. I'm going to skip that. Let's talk a little bit about experimental design. Experimental design, we've really spent a lot of time on it already. It involves everything from the formulation of the hypotheses all the way out to the conduct of your experiment. So the things that you actually do when you're designing your study, and this is more, again, not getting into the logistics of a study, because if you're developing a protocol and actually undertaking a clinical trial, there's many things beyond this. This is really just the design of the experiment to make sure that the measurements that you're collecting are valid. You have to have hypotheses that are well thought out. From those, everything else is built. So you determine what are the experimental conditions necessary in order to get measurements or data back that allow me to actually test the hypothesis that I have. So maybe you have a treatment and a placebo, or a treatment and a standard of care, or maybe you're looking at a dose finding. You're looking for the dose that's safe but also potentially effective. What measurements are you going to collect? So the outcome, again, this is beyond the scope of this study, but outcomes in experiments, there are certain characteristics that they need to have. They need to be valid. In other words, they need to be measuring the thing that you think they're measuring. They need to be reliable, which means that if I have two people who have the same condition, this outcome, if I measure it on them both, should be identical. So valid and reliable. Often whenever you're designing a study, you have multiple measurements that you could take on people, but one should be primary and should have emphasis in your determination, and it should be the best possible measurement that you could take. Any other extraneous conditions that you need to control for. So the way that these extraneous conditions could be, for instance, sources of noise, sources of bias. If you can either control for them in the design of your experiment by specifying the type of subjects, for instance, if this is a clinical trial, the type of subject that you will recruit and enroll on the study. Maybe they have to be premenopausal as opposed to allowing women of any age, because you know that maybe menopause is an important milestone that could affect a woman's response to treatment in a cancer study. So you either control for them or you measure them. You make sure that you measure them. Maybe you even include them if they're that important as part of your randomization. Specification of the number of subjects required. And then I've already alluded to your inclusion-exclusion criteria, the population from which they'll be sampled. Specification of the number of subjects required involves two things. First of all, how many subjects can you get within the time frame of your study? If the study is funded by the NIH, you've got a particular period of time to do it, and then your money runs out. So how many subjects can you afford? How many can you get? And then from that number, we determine how many you need to answer your question. And hopefully, the number that you need from a statistics perspective is below the number that you can actually get. So it's a feasible study. If the number you need is much higher, much greater than the number that you can actually get, then you can't do the study. Or you have to scale back the scope of your study. Yes?
How do you find out the number that you need ahead of time? Is that just like a guess?
No, it's not a guess. So the way that we do it here is you have hypotheses. You have your experimental conditions. So my hypothesis is I've got this really cool treatment that I want to investigate in let's say it's a randomized controlled trial, but it's kind of let's say it's a small randomized controlled trial. I have a specific hypothesis that this treatment will result in a, if under the standard of care 20% of patients respond, I think this one will result in a better response rate. But I have to specify how much better it needs to be before I want to move forward with it. So it doesn't need to be 30% response rate, 40% response rate, 25% response rate. So that either comes from you or the literature, what is acceptable in practice. So knowing the effect that you're looking for your specific hypotheses, your conditions, and then what it is you're measuring. So in the case that I gave you, you're measuring something to classify all of your subjects into either a response or a non-response. So that's pretty straightforward, because then you can just tell me, we can expect 20% of the standard of care patients to respond. That's well known. I want to see at least a 30% response rate before I move forward with this into a bigger study. So then the statistician does the math and says, well, you need 60 subjects, half in this group, half in that group, in order to have 80% power with maybe a 5% type 1 error rate at the end of this study. So, and then you say, well, hopefully you can get your hands on that many subjects and actually convince them to enroll in your study in the time period that you have available to you. So it's balancing a lot of things. There's a lot of back and forth, and there's a lot of compromise that you have to make. Maybe there's no way you're going to get that many, so you can try to do a multi-site. Maybe find people who will collaborate with you and enroll patients for you. That's a huge undertaking, because then you've got multiple places enrolling patients. They've all got to do the same thing and measure things in the same way. Or maybe you scale back and say, maybe I feel comfortable letting my type 1 error rate not necessarily be 5%, maybe it can be 10%. It's more important that I'm powered, less important that I make a type 1 error. So you kind of, it's all just a bunch of moving parts, and that's how you make it work. So specification of the procedure for assigning subjects to the conditions, it's randomization. Are you going to just do simple randomization? Are you going to do imbalance, where for every 2 that get treatment, 1 gets control? Are you going to stratify based on sex, stratify based on age? And then once these are in place, not once these are in place, but because we really need to know what the analysis plan is for the hypothesis in order to get to the sample size. That's what the power or the sample size estimate is based on. But there may be a lot of other secondary things you want to do with the data generated by the experiment. So to be transparent and to minimize our own human nature of fishing for things that we didn't think of until we got the data, we always like to lay out what statistical analyses will be done. So we hold ourselves accountable, if you will, to those kinds of things that we shouldn't be doing with experimental data. So now we're on to descriptive statistics, and then we'll finish up with this. If there's any questions, I can breeze through this actually pretty quickly, because you've all seen this. You've probably all done this in practice. And I want to end with a tool that I think it's important for you all to know exists, because it's free, and I think it's actually relatively user-friendly for a statistical tool. So again, I've alluded to the fact that with the 3 different areas, experimental design is really all the things that we have to do prior to an experiment and then during the conduct of an experiment to ensure that we get valid conclusions. Descriptive statistics or exploratory data analysis is the stuff that we start to do once the data comes in. We graph it. We do numerical summaries like means or standard deviations, because that not only allows us to determine the quality of the data, if you will. Is there any missing data? Are the measurements accurate? But it also allows us to facilitate the decision making that you have in play, that you want to do based on the results of your study. The methods that we use to describe the data are based on 2 things. And what I mean by this is, two of the most common questions I get are, how many subjects do I need, and what kind of tests do I do? So how many subjects do I need we'll talk about next week at a kind of a high level, but what kind of method do I use? We'll start to talk about that today. And the easiest way to think about that is ask yourself, well, what's my question? And then ask yourself, what type of information is included in the data that I've got? When I mean type of information, I mean, what is its level of measurement? Is everyone here familiar with levels of measurement? it kind of gets glossed over, but this is the foundation of everything that we do. You have to understand, what does the number 1 mean? What does the number 2 mean? 1 could mean male and 2 could mean female, or 1 could mean the number of days I was hospitalized or the number of rehospitalizations I had. 2 could mean the number of days I was hospitalized or the number of strokes that I had after something. So 1 and 2 could mean very different things. The difference between the two of them, so if I have a patient with a measurement of 2 and a patient with a measurement of 1, the difference between those two measurements, those two patients that I infer from that data could be very different depending on what information is contained in that data point. So if you start here, there's a really easy algorithm for getting to the appropriate method. Also, there's a really easy algorithm for going back and seeing the appropriate interpretation of whatever results that I have based on the actual information contained. So if you think about it this way, we start at the lowest, at the type of data point that has the least amount of information. That's what's called nominal, which means that if I have a subject with a 1 and a subject with a 2, all I know is they're different. I don't know that 2 had a better outcome than 1. I don't know that 2 had 2 times the outcome of 1. I don't know any of that. I just know that 1 is different than 2, kind of like male is different than female. I put them in bins. Ordinal takes that a single step further by not only having the feature of difference, but the feature of some kind of inherent ordering in their outcomes. So think of sports rankings. You know, first, someone's ranked first, someone's ranked second, someone's ranked third. All I know is that number 1 and number 2 and number 3 are different. Number 1 is better than number 2, number 2 is better than number 3, but I don't really know even how much better number 1 is from number 2. Or how much better number 2 is from number 3. So the difference between 1 and 2 and 2 and 3 is not necessarily the same difference. That's why it's ordinal and not the next case, which is interval, where we do impart meaning onto differences. So temperature. Temperature would be a good interval measurement because 10 degrees versus 20 degrees Celsius, if you will, we understand that one is different than the other, that one is hotter than the other, and we have information about how much hotter one is than the other, right? It's 20 degrees difference. It is not 2 times hotter though. If it was, that would be a ratio variable. So a ratio variable is any variable where ratios make sense. And the key to this is that there has to be some kind of 0 on that measurement scale that has meaning. So basically, if you have any kind of measurement where you can get a negative value and 0 is simply an arbitrarily chosen point, maybe it has meaning but it doesn't mean a lack of the measurement, then you don't have a ratio variable. And you shouldn't be doing ratios, odds ratios, risk ratios. Those kinds of things don't make sense. An example of a ratio variable could be number of rehospitalizations, for instance. So 0 means they weren't rehospitalized. 1 means let's say the average number of hospitalizations in group A was 10 and in group B was 5. I can say group A had 2 times the rate of rehospitalizations as group B. But only because 0 means nothing. Sometimes you hear these classified in a different way with different words. Categorical versus numeric. So by default, if it's nominal or ordinal, it's categorical. These are categories that you put people in or you put observations in. You might hear them called discrete. You might hear them called qualitative. The last 2 are more numeric. It means you can do more sophisticated analytic things with them because their number imparts some kind of a meaning. They are also called continuous or quantitative. This is where we do things like t-tests and linear regression and analysis of variance and the more mathematical type of statistical methods. Nominal and ordinal, we do those things like chi-square tests because we have tables, contingency tables of information that are where we classify our outcomes as opposed to imparting some numeric meaning to them. Obviously, if we were to look at this visually, I'm very visual, so I like to see this. Picture this as like a mountain coming out at us. So nominal, all variables are nominal, right? They all have that feature of a nominal variable because they all impart difference. If 1 is different than 2, it's different than 2 whether it's nominal or ratio. Ordinal adds an additional feature, so not all ordinal variables are interval because we add that additional feature of information about the differences here. And then the final variable type or measurement type ratio is the one that has all 4 of those characteristics. Difference, order, interval, information assigned to interval, and then an absolute 0 on the scale. So ideally, if we think about experiments in terms of maximizing information, we want to get variables, we want to measure things that have the highest level of measurement possible, which would be interval or ratio. But again, that's not always feasible, and it's not always necessary. We wouldn't want to necessarily, I mean, we need to measure sex, and there's no reason why it should be measured in any other way except a nominal variable. But if you have the choice between an ordinal category and an interval measurement, always record the interval measurement rather than categorizing it into less than 18, 18 to 25, 26 to 30, which you see a lot. Just ask for their age. If you want to bend them later into something ordinal to present the data, then by all means do so. You can always go from more specific to less specific. But if you've already recorded the data and all you know is this person is 18 to 25, well, there's a lot of missing information there. Information increases. Just quickly, ratio data, some examples of this. Oh, I'm sorry. My brain is working backwards. I was thinking I was going to start with nominal, but I start at the top because it's easier to peel away a characteristic. So starting at the top, ratio has difference, order, equivalence of intervals, and an absolute 0. So a good example of this could be length of stay, number of rehospitalizations, distance walked. Anywhere you have a 0, that means they didn't produce anything. Or there's a lack of whatever it is that you're measuring. Age, but things that are not ratio or things like temperatures. What other type of data do we have? I'm trying to think of examples. Anybody else have an example of a ratio measurement or an interval measurement that's not necessarily ratio that you use in practice? Besides the ones that I've already mentioned. Blood pressure. So blood pressure would be ratio because 0 means no blood pressure. Range of motion, unless, yeah, because you have a baseline, right? And you measure the degree out. Yeah, range of motion. So again, these things that we're talking about, it makes sense to talk about, well, someone could move 2 times as far or produce 2 times as much. So serum, anything that's, serum based, a serum marker, there's a level of detection below which you assume it's basically 0. But so those kinds of things you can talk about in terms of ratios. Fold changes. So anything that would, anything like that, you could talk about a fold change in an outcome. So you can make statements like twice as long or half as much. Examples are age, birth weight, tumor size, follow-up time, length of stay, time to complete a task, duration of survival, dose administered. These are all ratio, and we can talk about fold changes between groups if we want to. Interval data doesn't have that 0, so it doesn't make sense to talk about fold change or ratios. You can tell with interval data the degree of difference between observations. But again, comparisons using ratios don't make sense. Temperature's the easiest, and dates are easy as well. 60 degrees Fahrenheit is greater than 30 degrees Fahrenheit. It's actually 30 degrees greater than 30 degrees Fahrenheit on the scale, but it's not twice as hot. because 0 is an arbitrary point. Ordinal data, remove the intervals. Remove the meaning of intervals. And very often we tend to treat ordinal data like interval data, like we impart meaning on the difference between 3 and 4 on Likert scale data when we should not do that. So here all we have is difference in order. But the intervals, the difference between 1 and 2 and 2 and 3 and 3 and 4 are not necessarily the same. You don't make that assumption about that data. So examples could be the highest level of education achieved if you classify them into less than high school or GED, associate's degree, bachelor's degree, some college, advanced degree, whatever, however you tend to do that. The difference between those categories is not necessarily the same. Stage and grade of disease. So we do often staging. We use staging classification that have order implied based on severity, but are not necessarily, there's not a uniform stair step from stage 1 to stage 2 to stage 3. Survey questions like Likert scale quality of life should not be treated as if they're interval. Tumor response, complete, partial, stable, failure is also an ordinal outcome. And then nominal, obvious, sex or gender, ID numbers, pass-fail responses, anywhere where you put people or observations into mutually exclusive categories. So the reason I spent a few minutes on this is because that is the foundation for the next step of the process, which is how do we describe this information? Well, we have to base how we describe it on what it's actually conveying. And then further, how do we analyze it? Do I do a t-test or a chi-square test? So more mathematical operations, like the sample mean or the standard deviation, that can be performed on numeric data, but not on the categorical data. So interval and ratio data, it makes sense to calculate a mean. It does not make sense to calculate a mean gender or a mean something else. There are certain cases where in ordinal data you might choose to calculate or report a mean because it just, there's a way to interpret it, if you will. I'm thinking of like Likert scale data, quality of life type data. Methods for categorical data tend to have less restrictive assumptions, so there's the plus side. If I'm measuring a bunch of categorical outcomes, either nominal or ordinal, then they tend to be, the methods that we use to not only describe them but to analyze them are not really all that restrictive. We don't have to make sure the data is approximately normal, that the tails aren't too fat, that we have equal variance, and that the residuals are normally distributed. We don't have to go through that major process. Usually, tests or methods for nominal and ordinal or categorical data are really sample size based. So you have to have a certain number of observations before you can actually use the method, rather than what the data itself has to look like. The problem, though, on the opposite end of that is that these methods, because they have less information, feeding into them from the categorical data, they're also less sensitive to finding differences, less sensitive to changes. So that's why I mentioned earlier that if you have the option between collecting a measurement as an interval or a ratio as opposed to an ordinal, you should always collect it in its most specific, most informative form, and then you can always remove some of that information when you report it if you want to. So categorical data, describing that, we tend to do this in terms of tables. In tables, you often see this reported as frequencies, so how many of my subjects fell into each category, along with percents or proportions. For if it's an ordinal Likert scale data, you might want a mode, which is the most frequently occurring value, or a median. You would probably visualize it using bar charts, maybe a mosaic plot, or pie charts. Numeric data, you have to describe three things. You have to describe the center of the data, you have to describe the spread or dispersion of the data, and also the shape of the distribution. You have to talk about, is it symmetric about the mean? Is it skewed in one direction or the other? Are there multiple modes, multiple peaks? And we can do that using words or statistics and actual numerical quantities, but it's always easier, I think, in addition to reporting some common numeric statistics, numeric summaries, to give a picture. And that's true for any of these. A picture, in this case, if there's ever a graph that you can put in instead of a table that will do the same thing, do the graph. Because it's usually, it's quicker to interpret what you found as opposed to a big table. You're going to see that here because this table is actually, it's hard for me to read. So here's an example for, is myopia nearsight? Yes, nearsightedness. So a survey of nearly 500 children. They were investigating nighttime exposure and its relationship to development of nearsightedness later in childhood. So this survey, which this is real data, found that those who had slept with a nightlight or in a fully lit room before the age of 2 actually ended up having a higher incidence of nearsightedness later in childhood. So we have 2 measurements here. Their exposure, which is the nightlight or the nighttime light, and then the outcome, which is whether or not they developed this condition later in childhood. And you often see this kind of data reported in what's called a contingency table, where along the row you have one of the variables and along the columns you have the other variable. So darkness, nightlight, full light, that's how they slept before the age of 2, and then whether or not they developed nearsightedness and the degree to which it was diagnosed, so it was, I guess, regular or severe. And then you can see that the total columns give us an idea of the marginal totals of each of these. So you can look at the total column here and see the distribution of nearsightedness. The vast majority did not develop it, 71%. The 342 out of the entire 479. Only 3% or 14 developed a severe condition. And then you can see the exposure. This is a copy and paste error. This should not be 100%. So I apologize. The majority, not the majority necessarily, but close to majority slept with a nightlight. Some slept with full light, that's 75, and 172 slept in darkness. These percentages should be the percentage of the 479. So I'll try to get that, I'll try to remember to get that changed and send the slides back out. Then you can see within each of these cells, you can see this is kind of like conditional probability. If I'm only looking at those who developed the severe condition, what was their exposure? All these percentages, these are cell percentages. So this is 2, this is 1% of the 479. Sometimes we make a decision about whether we include row percentages or column percentages based on how we want people to read it. But again, it's kind of hard again in this table. But we can see there's not really an amazing pattern that's showing up within that group because we only had 14 children develop it. But we can see 7 and 5, 12 of the 14 actually had some exposure to light as opposed to only 2 of them in darkness. Compare that to the people that didn't develop the condition at all. 155 slept in full darkness. That's about half of the 342 who didn't develop the condition. So we can see a pattern here of increasing rates of darkness as we move from right to left across the table, but we have to really look hard. If you do it in a graph, it's a little bit easier. So this is a bar chart, and this is a great way of comparing groups, exposure groups on an outcome. So we have the exposure listed here, full light, night light, and darkness. And then within that, this is percentage-wise along the x-axis, or along the x-axis. What percentage of them ended up developing the condition? So high, severe disease is orange, and yellow is the moderate, and then the red is none. So actually the easiest thing to see here is that the yellow increases from bottom to top, and that the red decreases from bottom to top, where red is none. So basically the rate of developing this condition is actually, it increases as the nighttime light exposure increases. So you could make the statement here that the amount of sleep time light is associated with the incidence or the development later on of nearsightedness. But again, this is an observational study. It doesn't prove that this is the cause of their condition. There may be confounding factors that aren't measured or considered. For instance, one that could, if I was peer reviewing this paper and they were saying this causes that, you could say, well, what about genetics? If these individuals, these children, have parents who also have the condition, they're probably more likely to suffer from it themselves. And it's also possible that the parents who have the condition are more likely to provide light while their children are sleeping, just as out of habit, because they need it in order to navigate at night through the house. So a very common example of a confounding factor that often occurs in observational studies. I'm showing you this. This is a dose from a distribution of doses that resulted in nausea or not, so like an adverse event type of analysis. One thing I wanted to show you here is the common mistake that we see where we report on the y-axis of these bar charts the number of subjects who experienced it when we have very different sample sizes in the groups, because it looks like it's hard to interpret overall, and it could be misleading. What we want to do really is use percents rather than frequency, because if you see here, look how the no nausea group completely changed direction. So a rule of thumb is if you have groups that have unequal sample sizes, make sure you're reporting percentages rather than frequency. You also need to give somewhere the group sizes for reference to be transparent, but visually you need to do it in terms of percentages. Bar and pie charts are options in some cases. Here we have histogram in time to death. This is for a continuous outcome. So the x-axis is time to death, and this is measured for 100 patients in a study, and we can see very quickly, much more quickly than we could if we were reporting just a table with the median time or the mean time and some kind of measure of variability. We can see very quickly what happened to the patients in this study. That the majority of them, if this is in months, the majority of them lived to 5 months, oh no, I'm sorry, died within 5 months. And then beyond that, we had a couple of individuals who lived actually out to 15 months or beyond. Box plots are very useful for summarizing. So a histogram summarizes a continuous outcome, either numeric, it's any numeric outcome. Box plots do the same thing, but they do it in a more effective way when you're trying to compare multiple groups. Wouldn't make sense to have a histogram overlay to histogram. You can do this very easily by producing box plots. Here we actually have two factors. We have two different supplements, the green supplement and the yellow supplement, and they were also given in different or increasing doses. I don't remember what the unit of the dose is, but half, 1, and 2, and you can see there's an increasing relationship between increasing doses of the supplement and tooth growth, because the box plots are shifting up the y-axis, but you can also see overall that the supplement that's represented by the yellow at these lower two doses is outperforming, if you will, the green dose, the green drug, until you get out here, and then they're very similar. But this allows you to very quickly visualize the center of the data, the spread of the data by not only the box itself, but also how far out the whiskers go. And we'll talk more about box plots whenever we get into the methods in the later lectures. For continuous data, we also have to describe numerically a couple of features. The first is the central tendency, and there are a couple of easy ways of doing that. The one that's probably the most common is the mean. The mean is just the center of gravity. If we picture this to be a trailer where there's a heap of dirt on top of it, the mean is actually located at the fulcrum. In other words, where would I need to put the wheel, the single wheel axle, to balance this out, where it wouldn't lean one direction or the other? And that's the physical interpretation, the physical meaning of the mean, because it takes into account the actual value of the measurement in its calculation. The median is different. It gives you the approximate middle of the data, and it actually doesn't even take into account the measurement itself. It strips their actual values after it's rank ordered them, and then just takes the middle value. So you could have a very skewed distribution, and the mean would want to shift toward that skewness to balance it out. The median would not move that much because it doesn't take into account the actual value of the data. And then the mode is just the peak. So in this case, whenever you have a nice normal distribution, the mean, median, and mode are all the same. The mode is very useful for discrete measurements, like whenever you're talking about in a population, what's the the political affiliation, for instance. You might say they're mainly Republicans in this particular sample that I surveyed. Again, just like we mentioned before, the mode is very robust. It's very meaningful for nominal variables, any variables that are inherently discrete, but it can vary widely from sample to sample. So if I took a sample of size 10 from a population and reported that I had mostly females, that's the mode, and you took a sample in the same way of size 10 from the same population, you might get mostly males. So it really doesn't have as much meaning in that sense because its sampling stability is very low. This would be the mode in a continuous distribution. That would be the mode for a category like gender or sex. The median is the 50th percentile. So what you do is you strip the value of the observation itself and you order them, and then you take the middle point. So because you're doing this, you're removing information. So it's not as sensitive as something like the mean, which actually incorporates all the information, but it's robust. Because if you think about it, if you have a single unusually large or unusually small observation, the mean will use that information, and it might actually move or shift or be biased in that direction, especially in small studies. The median would not, because it doesn't care how far out in the tail that observation is, just that it's to the right or to the left of the observation that it's next to. So it is robust, but it's less sensitive, if you will, than the mean. And it's appropriate for ordinal and interval and ratio measures, in particular when those interval or ratio measures have skewness or outliers. It has the similar problem as the mode in that it varies from sample to sample quite a bit. A good example of its robustness is the example where 4 and 9, which are two very different observations, in a very small data set actually result in the same median. So if I have 4 subjects and their outcomes are 1, 2, 2, and 4, the median is the 50th percentile right in the middle, which happens to be 2 here. For whatever reason, maybe we have an outlier. This one actually, maybe that's a true 9. It's a true 9, it's valid, but it's very different. So the mean would follow the 9 out there, and it wouldn't really report the average, the true average, or the true middle of the data, whereas the median, it again doesn't care. That's the 4th observation. It's to the left of 2. I don't care if it's 9 or 900. My median will still be 2. So the median here is really reflective of the quote-unquote average or middle of the data, where the majority of people tend to fall. It's central tendency of the outcome. The mean, again, is the most mathematical. So it actually is the most, it provides the most sensitive measure of central tendency because it takes into account all the information in the measurement. But it is affected by extreme values because it takes into account the magnitude of every observation. The benefit of this, though, is that it has very good sampling stability. So when we talk about it being like the best estimate, it's because it actually, from sample to sample, if I did an experiment and you did an experiment and I calculated the mean and you calculated the mean, it will differ less between our two studies than our medians would or our modes would. So it has good sampling stability. So it's more reliable, if you will, because it doesn't shift as much from experiment to experiment. And back to that example of the mean, where we had the median stay the same, but the mean actually changes. It's pulled upward from 2.25 to 3.5 simply because we have this one unusual observation. And you can see visually where the mean happens to go. It follows the tail. The mean always follows the tail. Variability describes the spread. There are many ways that are kind of analogs to the mean, median, and mode that you can describe the variability in data. The range simply gives the minimum value and the max value and the difference between the two. So it gives you the full spread of the data. You can see the problem with that is that if you have unusual observations in either tail, outliers in either tail, it will overinflate. It will make the data look more variable than it actually is. The standard deviation is an average. It's the average distance between observations and the mean. So it's another average. So all the problems or good things that you have accompanying the use of the sample mean, you have them with the standard deviation because, again, it just takes the distance between every observation in your data set from the mean of the observations, and it just averages them. Here's an example of the range, how the range can be extremely influenced by outliers, either a data entry error or a truly different responder. So if I had 1, 2, 3, 4, and 10, the range would be 9. But if I had 1, 2, 3, 4, and 100, either because I hit an extra 0 on accident or because there was actually a 100 in the data set, the range now looks like 99. That's misleading. You can instead use something a little bit more robust called the interquartile range, which basically chops off the tails. It takes the lower quartile, the lower 25%, and the upper 25%, and removes them and then computes the range of that inner 50%. So it's just the distance between the first quartile and the third quartile, and it's not influenced by extreme values because of that.
Sometimes I hear interquantile range.
No, it's the same thing. It's, yeah. Well, unless they're using a different quantile, because if they, for instance, are using the 90th, like 10% and 10% on the tails, or 40% and 40%. So I think as long as they're not giving you a percentage, a quantile that's different from the 25th and the 75th, you can assume that it's the interquartile. And this is, if we look visually, how we would see it. So you often see the interquartile range or some function of it represented on a box plot, and it's the box itself. It's the middle bulk of the data, the middle 50%, and then the tails could represent the spread beyond that middle. So if I have something perfectly symmetric, which I have here in this histogram, you would see symmetry in our box plot as well. The standard deviation, again, it's an average. So all the things I said about the mean apply to the standard deviation. It is affected by outliers. It will be larger whenever you have unusual observations. The benefit of it, though, is it's sensitive. It has very good sampling stability, so it doesn't change much from sample to sample. And also the reason I like it as opposed to something like the variance is because it's presented in the same units as the original data. So if we talk about range of motion, someone mentioned range of motion, what are the units of measurement of that? Is it degrees? So if I reported the average range of motion along with the variance would be like 10 square degrees, which I can't visualize. But if I were to report it in terms of the standard deviation, let's say it was 10 degrees would be the standard deviation. So then you could kind of visualize, here's the average, and a standard deviation below and above gives me kind of an average spread of the data. So it's more interpretable, I think, than the variance. And in fact, the relationship between the two is just you take the variance and you take its square root. Or you take the standard deviation and you square it and you get the variance. And finally, the shape. There are many different common types of shapes. This is the bell curve. So it's symmetric and unimodal. You can say it's approximately normal. This is a skewed distribution. So here, the mean, median, and mode would all kind of give you the same conclusion or same information about the distribution, as would the range and standard deviation and interquartile range. They would all kind of be adequate measures. So in that case, the most sensitive and the most meaningful would be the mean and the standard deviation. But here, we've already talked about the problems with the mean, the problems with the range, the problems with the standard deviation when we have unusually large or small values, which is what this tail is. So if I really want to describe the bulk of the data, which is right here, kind of centered right here, I would want to use more robust measures like the median and potentially the interquartile range, which would cut off this inner kind of 50% and give me a better idea of where the vast majority of measurements are located. But that's right skewed or positively skewed. This is left skewed, and it's bimodal. So you see this often whenever you're taking a measurement in your study or in a population, and there are actually two subgroups or two subpopulations. There's one group that's kind of here. You see there's like almost like a normal distribution here. And then there's, something of a normal distribution here. It kind of truncates at this value. But this would give a lot of insight into what's underlying your study or your observations. You can think of it this way. If we were to plot, maybe this is premenopausal and postmenopausal women for something. And so if you could identify those subgroups, then that would really further along your knowledge about what it is you're investigating. The slide's not advancing. Give it a second. I think it's thinking. There we go. And again, many different ways of looking at it. So the ones that I showed you were smooth curves. Generally, though, we're doing this in the form of histograms or box plots. And you can see all the different possibilities. You also see things that are like bathtub shaped, which means the most frequently occurring values are actually at the ends, and the in between the two is less frequently occurring. And finally, I wanted to, and I will use this to demonstrate some examples in the next 3 weeks. I wanted to bring to your attention a tool called RStudio. RStudio is a free set of integrated tools that's designed for programming, which you might not want to do, but it's also designed for statistical analysis. It is free, and it has amazing online help. And it's what's called an IDE. RStudio is an IDE for a programming language called R. So the IDE is just an environment that's much more user-friendly. So how many of you have used SAS, programmed in SAS? It's programming like SAS, but a little more user-friendly than SAS. So you still have a lot of the control. In fact, you actually have more control in RStudio than you do in SAS, which uses a lot of procedures with black boxes. It'll run on any type of operating system. And I think that there's an amazing online community. So if I know a lot of people try to find free tools. Has anyone here ever used R or RStudio? Do you all like it? Yeah? Yeah. It's very good for plots and diagrams. Very good for plots and diagrams.
This robust, I guess, for common aspects like survival analysis.
I don't know if it's less robust. It's just open source and free, and there's many different ways that you could do it. So I will say, and that brings up a good point, that SAS is what's called a validated software. It's a product that's produced by a company that's making money off of it. They have developers, they have people who test and verify that the black box that you're putting your stuff into is putting out what you think it should put out, and it's rigorously tested. Anything in R, beyond probably the most common functions, you really need to make sure you understand what it's doing. Read up on it, because this is open source, so you can actually see inside, you can see all the code that produces the result, which you can't in SAS. SAS, like if you do a proc mixed, you give it the information, the model statement, and then it produces results. You have no idea what happened underneath. With R, you can actually open up the black box and see. But that assumes that you have the training and the knowledge to actually understand a lot of the intricacies, and you may or may not. But a lot of the more common functions, like the t-test or all the power, the things that you can use to calculate power of a study, those work, and you can go online and Google, is this, or what are the issues with t-test, and you'll find people on blogs and forums and things that it'll come up in the very top, because people all over the world are contributing to this environment with their code. So there's probably someone who's written the code that you need in a very user-friendly function. Our studio, I don't have it loaded on this machine, but they have a lot of webinars and videos and training and stuff like that. It's free. You can download it. You just want the desktop, and you just tell it whether you're Windows or whatever, and it will tell you. R Studio is just how I interface with this programming language called R, so you also have to download R. So if you don't have it on your machine, you have to download that and R Studio that way. And you can actually just work from R if you're a more advanced programmer and you're comfortable with it. But R Studio provides a lot of features that are very user-friendly. So we'll work a little bit with R Studio in the next 3 weeks. So if you have a laptop and you wanted to bring it, you can do that. I'll send you the code and the slides. But are there any questions or discussion that needs to happen for this first bit of material? I think I sent them this morning. If you are on the registration list, you should have gotten a copy this morning. I got quite a few people that asked about them. So I'll send out the next 3 weeks. I always make last-minute changes, so I don't like to send them out too far in advance. But I'll look through and make sure that I don't want to make any more changes to the next 3 weeks and send those out so you can print them if you want. Okay, well, I will post this recording sometime this afternoon on the Biostats webpage if you wanted to review. If you have any questions, feel free to send me an email. Thank you all. But if you need parking validated, if you came from off campus and need your parking validated, that's a good idea. That's true. Yeah, that's a good idea. We'll see if I remember that. I'll try to remember it.
There's a lot of great Stack Overflow. It's like, how do you do this? And then
It comes right up. I don't even go to Stack Overflow. I just type it into Google, and it usually takes me to Stack Overflow. So yeah, it's got great information.